let me give you a background about the national subnational implementation of stigma and discrimination in the Philippines. So, hi, I'm Ildebrando Ruaya. You can call me Ilde. I'm a quality improvement specialist under the Sustained Health Initiatives of the Philippines. For my presentation, it will just walk you through the following. First will be the QISD journey in the Philippines. The second will be the QISD implementation of the two sub CBO lead in the Philippines, and three is moving forward. So, where's the? I'm sorry. I'm not comfortable with that. Thank you. And just a short journey. The Philippines setup is initially the stigma and discrimination has been initially introduced by Prismid and SHIP. It is supported by the health ministry, but not until not yet integrated to policy development. During the initial and second round of stigma and discrimination, we have included hospitals and community-based organizations. The implementation is very grant dependent. It includes the project managers, the QI consultant, and the hospital coordinators, which leads to a sudden drop of implementation in 2022. As you can see, initially we established the baseline and run the second run of data 5 months after the initial. And we have presented last November about the 2 years later follow up, and this is the year for us. And I will be informing you about how we will be moving forward for this 2 years follow up. For the hospitals, we have included 13 sites previously, but QISD surveys are rare. They haven't integrated it in their good clients' feedback because they have different feedback mechanisms. They have client surveys based on the different structures, either a government or a private institution. It's very dependent. And however, we have their implementation, they still continue to provide orientation to their employees, especially for the newly hires. There is a decreased stigma and discrimination anecdotally, and we'll implement project in the future. So that's why we have invited them again to join our third round of stigma and discrimination. For the CBO or community-based organizations, we have two CBO-led clinics who have invested in QI mentoring. They have continued interventions to the proposed identification of registration form and feedback surveys, which I will present to you some of their highlighted results and activities. The survey is the one clinic maintained the QISD survey. Actually, you will also see later on, like they have used a cost client feedback plus stigma and discrimination, which is a hybrid one. But you will also learn that there are challenges during the implementation. First, I would like to feature the first CBO, which is the Sale Academy. As you can see, this is a clinic in one of the highest, most populated city in the Philippines. Usually operates from Monday to Saturday. However, because of the surge of the demand from the clients who needs care, they open for Sunday. And they look at further quality measures like enrollment and like waiting time. However, if you're going to operationalize waiting time and take note of their turnaround time based on the documentation, it's very hard. So that's why we use a feedback mechanism, a client feedback, which is divided into three. One, focus on service quality and convenience. Two, availability and responsiveness. And three is the competent healthcare worker based on the perception of the client. And for this clinic, we will featuring the one response which more focused on convenience and checkup booking, waiting time, and administrative procedure. So the result of this clinic is there. So as you can see, they use a measure because as we mentioned earlier, they haven't actually defined what will be their measuring. So when I came to them, I coached to them like, why not we target like at least 10% of the clients who report unsatisfactory experience with the waiting time in accessing services. It assumes that 90% is very satisfied with the waiting time. In November 22, when we presented this one, and we have recall all the data, we have conducted process flow charting with the clinic team in January, and we look at well, we're the part of the process of bottlenecks and delays in the waiting time. And we have observed improvement in the waiting time based on the feedback of the clients. However, in April, it almost went over the target. But as you can see, it's unleading there. Then the number of clients feedback received were below daily average. There's a need to revisit the sampling approach in collecting clients' feedback using QR code. Why? The clinic did not offer a paper-based client feedback. They just post in their in the doors or after the consultation wall or in the bulletin of the clinic for a client feedback QR code. So what's the limitation of this? And we learn from it. This clinic developed a dashboard which they use during operations review monthly. So as you can see, when we compare the foot traffic per service accessed by the client for this clinic, they almost run the same over from September to April. And what is observable here is that because of this initial implementation, we understand that we need to set an average daily client feedback to be received. And as you can see in April, it is below the average daily feedback, which has been generated from the previous months. So the next measure will be they should be targeting at least 12 feedback to be collected within a day. And they will design sampling method on how to collect and ensure that you will receive 12 feedbacks or more. So to prevent to remove the bias in the data. As you can see, this dashboard is an initiative of the sale clinics. It's still on the first rank actually. We will revisit all the data elements in the future. The second is the sale intermediate, which they focus on the identification, and we have the QI project called the Basic Client Care Training. And when we conducted a process flow charting, I informed them to focus on the identification and looking at the reported clients that we have experienced stigma discrimination because of the violation for their data privacy and confidentiality. So this clinic, since they are part of sale, they underwent a sustaining and enhancing customer service experience as we introduced last time, that as a sex E, which has the purpose of communication skills and personal interaction skills, because we found out that some of our clinic staff were not good in interacting with our clients or responding to queries. And as you can see, this team is the QI team for communications. They focus on developing staff and how to communicate properly, how to respond, and to be therapeutic with the clients. Because of this intervention, this clinic, no, okay, now they have developed on how to respond to inquiries. They have, if someone is looking at for prep, they will send this information materials that is developed by the communications team. If they would like to ask appointment, they will provide link where it can be access appointment. So basically, they have developed a standards way on how to respond to queries for the clients in terms of social media inquiries. The next thing is looking at how well will be performed using these interventions. They also use the feedback. And as you can see, they focus on looking at these statements: responsiveness and competency of healthcare workers, which includes the mental confidentiality. For the data, before 6E training and the identification activities and the development of feedback messaging responding to inquiries by social media, there's a high rate of reporting that the clients receive inappropriate or somehow very stigmatizing responses from clients. And because of these interventions, over the past months, we have observed an improvement with the response about unclear responses from the inquiries we made, both personal and both online. The next thing is all about the competency. And I coach them like, okay, when we say competent, maybe we consider 90% of our clients is reported to be competent. And our clients should report them as they receive their care from a competent healthcare worker. And this XE, starting November, it gave us a good result. And furthermore, we enrolled some of the case managers and community-based motivators in what we call HTTP, or the HIV telehealth training program, where they will learn a lot about SOGI, gender identity, how to manage HIV care, how to communicate with them, how to determine mental health. It's a 14 weeks, 4-hour session. So it's a long run of online training. But we have observed an increase in terms of reported confidence from our clients that they receive care from a competent healthcare worker. Over time, we observed that during April, there is a decrease in the reporting. Again, because of the number of client feedback that we receive over time. And also, we are planning to revisit the competency level of our healthcare workers in the community. So, um, that's the accomplishment so far based on the initial. However, this clinic top management is very committed to QISD, and they say, "Oh, we're implementing service quality. We now measuring availability of responsiveness. We are measuring competent healthcare workers. How it will affect the stigma and discrimination." They add up now to their survey tool in the QR code the 7 questions you have the same here, but I will just be reporting to you about the number 7, the last one. If you have experienced the stigma and discrimination from healthcare provider or other staff. Surprisingly, we thought we decreased the stigma discrimination in January to February when we used the arrangement of the questions that the question about discrimination from healthcare work experience on the last part. This is evidence that if this survey, an additional survey to their client feedback, gives them a survey fatigue. And they just answered yes, 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 yes. And until the last number, did you experience stigma and discrimination from the client survey provider? Yes. That should ask the number. It's not unique with one clinic because it happens also. Okay. With the other clinic. So as you can see. Now when we revisit the answers and we observe that there's a survey fatigue. We rearrange the question. From the 7th, from placing the question about discrimination experience from healthcare provider in the 7th, we put it in the first spot. And as you can see, during March and April, we observed that our interventions for the 2 CBOs has really improved the stigma discrimination they experience in healthcare setting. So those are our learnings during our QI implementation. And finally, note that it's a reality. Okay, so initial implementation, this CL clinics has been doing some peer exchange because of the presence of their QI specialists. We have been meeting with them, although with pandemics and even virtually. And what's good with these CL clinics is that every month their QI initiatives were reported to the top management. They communicate with them, and that's why problems in data management have been addressed. For QI training and coaching, for hospitals, we need to engage them more and develop QI mentoring coaching plan. For CBO leads, we need to have a needs-based QI training, and we are doing designing a knowledge-based knowledge needs assessment for QI. And data has not been shared for the national level yet due to limited implementation of QI activities. But we're moving there. So last year, we reported that the challenge is QI needs to be standardized in HIV service delivery process. I highlighted here having policy that address the need for government program to provide sustainable resources for its delivery. Health ministry must be engaged, and we're very much happy that for the second run of our multi-country network meeting, we have the Department of Health with us. And moving forward, We have the HRSA QI project. We have and reintroduced and emphasized QI in healthcare for our hospitals by using we're happy to be a recipient of UCSF-HEALTHQUAL Philippines project. And the first is looking at the DOH strategic engagement with the development of the National Quality Framework. And so far, um, we have done series of meetings with the Department of Health with Bruce and our USIC Roquillo, who is the governance, and Dr. Billy Mack and the team. And this is Caroline from the HRSA. So they're supporting our QI Learning Network project in the Philippines. For objective number two, we have actually four networks to run, but I will just focus for stigma and discrimination. Um, we have we will be covering 13 hospitals, seven community-based lived organic clinics all over the Philippines. So we have representations from Luzon, Visayas, and Mindanao. Then we have successfully launched our first QISD learning network in the Philippines last May 17th. We have Dr. Loyo Campo as one of our speakers describing about zero discrimination in the Philippines experience, and we have Dr. Bruce Ians on refreshing our participants about HIV stigma discrimination in the healthcare setting. That would be all. Thank you very much.